We're going to now switch to the second topic, which is all about community health workers, what community health workers are, where do they work, and then hopefully we can have a conversation about how can community health workers fit in with serious illness care. So we have an amazing collection of folks who are speaking today. I really am grateful. So we'll just jump right into it with our first speaker, who is Hilary Hacker. And I've asked everybody to briefly introduce themselves.
All right. Thank you so much for having me. Nice to see everybody here. I see a couple of familiar names. So I'm excited to see what comes of this conversation today. So thank you so much for hosting, Kōkua, Jeanette, Hope. All right. So my name is Hilary Hacker, and I work as the director of the Community Health Education Program at Kapiʻolani Community College. It's a new program, sort of kind of combining a few new programs along with the Kupuna Education Center, which has done a lot of really amazing work in the community over the years. And so we've just kind of reorganized things a bit so that community health worker program has a home. We're also working towards community paramedics. We're starting our first community health worker EMT cohort this summer. And so there's a lot of exciting things happening, a lot of change, but just really getting off the ground. So I'm really, really happy to be here with you all. So I have worked with the Community Health Worker Program at KCC prior to this current role. I've worked there in many different capacities, from lecturer to program coordinator to recruitment facilitator. And so I love this program and I love all of our students, and we have one here today. I'm very excited that she's going to be able to share with you about the amazing work that she does. So I will just get started. So this is just a little bit of what we're going to talk about over the next, I think, 20 minutes or so. Correct me if I'm wrong, and feel free to stop me if I go way over. So what is a community health worker? Where do they work? What are their jobs, and what do they pay? We're going to look at some quotes from some people, and we'll watch a short video about the values of CHWs. And then we're just going to talk about our curriculum, the Community Health Worker Certificate at Kapiʻolani Community College. We'll share a bit about our curriculum and what kinds of trainings, what kinds of training CHWs are prepared with, are experiencing, and then graduating with knowledge in those areas. We also have a practicum component to our certificate. The last course in our certificate is a practicum. So students are working out in the community in various capacities. So I want to talk a little bit about that and how you might be able to host a practicum student at your site. All right, so we'll just get started. I guess I always like to see how many people know, how many people have heard of community health workers. I know I can't really see very many of you, but how many people have I? Yeah, a bunch of people. Yeah. Okay, awesome. So some of this will be a refresher, and maybe you can help add things in chat or something if you feel like something's missing. I always like things to be a conversation with the group. So we're just going to give a brief overview. So community health workers work to link disadvantaged and vulnerable populations with existing healthcare resources. So this is carried out by providing basic health screening services, identifying needs, providing information, making referrals to appropriate healthcare providers or agencies, supporting community-based research, health education, and following up on referrals. I think there's probably more to add to this definition, but this is a good place to start. Why are they important? So CHWs are definitely a valuable member of healthcare social service teams. They provide people in need with health education and care coordination, help to facilitate access to services. They work with clients to take steps to improve the quality of their health and their lives. And most importantly, they are trusted individuals of the community which they are serving. So they often come from the communities that they're serving. And if they're new to the community, they have really beautiful skills at building rapport and connecting with people and really having cultural humility. And so CHWs are very important. Okay, so where do CHWs work? This is just a few examples. Community health centers, hospitals, clinics. We have CHWs throughout Queens Medical Center, Hawaii Pacific Health, and a lot of physicians' offices are actually using community health workers these days. We have social service agencies from Achieve Zero, Project Vision Hawaii, Halekipa. These are just to name a few. I think that this list has grown exponentially over the course of COVID. And then insurance companies are also employing community health workers to work with their members and support them to navigate their care. So yes, as I mentioned, this list is really grown over the years. And also as in terms of who's accepting our practicum students as well, we have a lot of students throughout all of these agencies and more. And then for those of you who don't think that you've heard of a community health worker, haven't necessarily heard that specific title before, this is just a list of sort of a lot of the different job titles that you will see that represent community health workers. So they're not necessarily defined by the title community health workers, they're really defined by what they do. And so we have, here anywhere from case managers, health advocate, health educators, community researchers, patient navigators, peer counselors, and I'm sure the list goes on, but these are just a few examples. So maybe some of those of you who maybe didn't think you had heard of a community health worker prior to seeing this list, maybe this makes it feel a little more familiar. So the types of working conditions of community health workers are working in clinics. A lot of our emergency departments are staffed with community health workers, patient navigators, helping folks to find alternative ways to find support and resources that they need, and just have alternative ways to access care, right? Versus continuing to visit the emergency departments. Serve as agency offices. CHWs are really helping people with telehealth. And supporting different kind of tech companies that are helping to decrease loneliness in our aging population. And then there's folks on the street doing street outreach, connecting with people where they're at. And then of course, liaison with policy and lawmakers, and then also doing research and community surveys. This is kind of some old data. I do need to update this, but as of May 2021, we found that 61,000 CHWs were employed in the US, and then 500, I would think more than 500 in Hawaii today. And then the hourly mean wage should be about $23, annual mean wage, about 50,000. So this is just sort of an average of what we found. But as I mentioned, we've seen these job openings just kind of skyrocket throughout COVID. We're getting them sort of weekly. We're getting positions that are folks that are looking for community health workers. And then I just wanted to share, I have a couple quotes from people that I really liked how they talked about community health workers. Catherine Matayoshi, the Senior Vice President at HMSA, she says that healthcare challenges are not limited to the number of doctors or healthcare facilities. A complex health system is not easy to navigate with language barriers, cultural barriers, transportation barriers, and more. This is a real need for trust. Community health workers can bridge all of these gaps. What I love about community health workers is that their role values assets that are sometimes not treasured by the overall system. People who can speak multiple languages, valued relationships built over time, deeper understanding of the history of a community, and the interrelated complexities of getting the most basic needs met.
Hilary, you're muted. Sorry.
Okay, I was trying to move my bar around and mute myself. I hope it wasn't too long, but you probably just missed my mumbling. Okay, so, and this is just another quote from Ashley Schreer, Director of Care Coordination at Queen's Care Coalition. And she talks about CHWs that our CHWs can build trusting relationships in minutes or hours instead of months or years. They really do start where the patient is at and let the patient identify what their barrier to care is. They literally start where they are at, whether that is a sidewalk, a bridge, or in a home. We have seen some incredible outcomes. Highly effective to reduce unnecessary utilization of the healthcare system. We have driven down unnecessary ED visits by our patient population by about 50% and driven down their total cost of care paid for by Medicaid by 35 to 40%. So doing great work at Queens. And here's just a quick video. It's an excerpt from a larger video. It's Malama i Keola. It's a health center on Maui using community health workers.
The community outreach program and the community health workers have assisted tremendously with that, having hands-on direct translation for us, but also assistance with understanding the cultures of the Pacific Islanders, which are often very different from ours, and present a tremendous hurdle in helping them.
That's my dream and hope. That's why I want to do this, because one day before I got hired, I was just praying, oh Lord, is there anything that can help my people? So I just came in and I feel like I'm contributing to my people. And I want it to continue. And if it can reach my island, that will be a great blessing.
The trust system is there, you know what I mean? Because of how she come, because how she present herself. After that, I already comfortable. Just when as soon as she start talking, she made me feel at ease. It's like I'm talking to my auntie or my mom. You know what I mean? That's how I feel over here.
Everyone helping me with my problem, thank you. To anyone who shares the same problem, all I could say is stick to it. You'll get there. I'm getting there. You can get there too.
I have a dream, if I can I have a dream for a better life. That's what I believe.
You know, if you have the right people and they're doing the right things to help everyone have access and resources and education, that you can change the community.
The community.
All right, so I'm going to move on to talk about more about our Kapiʻolani Community College Community Health Worker Certificate. And this slide, I just sort of kept it in. It's from our info session slides, but I just wanted to share with you, we are currently funded through a HRSA grant, so tuition is covered. We do provide books for our students and wraparound services for support. We help folks to get connected with ELL and tech support for adult learners. And we also have laptops and hotspots. So we've really done a great job of building our resources so that we can really community health worker our community health workers so that folks have access to our program. And then folks receive 16 college credits and a certificate of competence as community health workers. So our curriculum here, I'm just going to share a little bit about our curriculum. I'll kind of go into each of the classes. We do have 5 classes in the program. So the first 4 classes are 3 credits and the last class is 4 credits. So that community health worker practicum is a little bit more intense. So it has an extra credit added to it. But I'll start with the CHW 100. So community health worker fundamentals. This class is really an intro to community health work. We talk about the history of community health workers. We talk about sort of how to navigate. We talk about how to navigate the systems, the health systems and social service systems, so that we can best support people to do that. We talk a lot about ethics and boundaries and self-care. When we get into our CHW 130 class, this is our introduction to counseling and interviewing. This course is really fun. This is a really skill-based course. So we're really practicing kind of our effective listening skills, how we're asking questions, facilitating conversations. We're talking about patient-centered care and strengths-based approach. And so we're doing a lot of practicing different skills through role play with each other. How can we really support clients to create change for themselves? Rather than, we're not telling people how to change or how to create change. We're facilitating their own needs and their own desires for themselves, for their lives. So this is a really, really powerful class for a lot of folks. It's one of my favorite ones to teach. And then we get into our 135 class, and that's the health promotion and disease prevention. So this is sort of an intro to public health and We talk a lot about sort of change on that community level. So we go from that individual supporting folks to create change on that individual level to how do we do that on a community level. So we talk a lot about health education, group facilitation, community mapping. And then we get into our 100 CHW 140 class, and this is our case management course. It's really an intro to case management, really building off of that 130 class, introduction to counseling and interviewing, and really supporting folks through the stages of change, and kind of navigating through a case. How do we kind of open a case and close a case and support our folks through whatever challenges that they're focusing on. And then we get into the practicum, community health worker practicum course. That's our CHW 145 course. And this is when they can put all of that into action. So they're spending 120 hours in the community at an organization or agency of their choice. And they're able to sort of practice all of these skills. I don't know that okay, so this is just a little bit more 50 hours of class time. So they're still going to class synchronous and asynchronous, but it's 120 hours of on-site. So this looks like about 10 to 15 hours a week, depending on when folks get started. Ideally, we can get folks started right away as the semester starts and people can really hit the ground running. Students create a learning plan. Yeah, so students are going to create a learning plan. They're going to think through maybe 3 to 5 goals, things that from the curriculum that they really want to continue to work on or put into practice. And they're going to bring that to the agency or the organization supervisor and talk through kind of like, is this possible for me to work on these things here? Or what are some things that I can learn? What are some things that you would want me to work on, and how can I benefit from that? So it's really meant to be a collaboration between the agency and the student. So students will come with some ideas, but everyone's prepared and open to obviously collaborate and of course meet the needs of the agency and organization as well. So the goals of the practicum are for the student to have a professionally and personally rewarding learning experience that includes guided and supervised work with agency clients at an agreed upon level of interaction. And then, of course, for the agency staff and clients to benefit from having a CAP-CC, Community Health Worker Certificate Program student, contribute positively to the agency and client population served. So these are some of our upcoming practicum dates. We have our summer session happening, obviously this summer, May 22nd through August 11th. And then in the fall, we'll have, I was thinking we had more students in the fall, but we have more students in the summer. So in the fall, August 21st through December 15th. And then we have the breakdown by island here. Our program is statewide online. Actually also do offer a couple in-person cohorts. We're currently offering an in-person cohort at Kokua, Kalihi Valley at the KPT. And then we have an in-person cohort at Waianae Coast Comprehensive Center as well. And we've got some folks on that program who are Zooming in from Lanai. So we've been able to sort of kind of serve more targeted populations through this newer grant. Some people the online works really, really well for, and some people really need that in person. So we're doing our best to accommodate. Okay, just some agency advantages and benefits. Knowing your practicum student has a basic understanding of the attitudes, skills, and knowledge of professional social service and community health worker, often in the area of the client population you're serving. It's also just a great opportunity to discover new talent. It just provides a great opportunity to see how the student fits within your agency. And, students can potentially be offered and accept jobs upon completion of the practicum. We've had a few sites that offer stipends throughout. We have a few sites that are unpaid, and we have sites that have hired our students upon completion of the practicum. And then, of course, help your clients as well as reduce staff workloads while helping the practicum student develop confidence and competence in the field. And then students can bring unique strengths in working with these issues at your client's space. So they have been exposed to evidence-based helping strategies and skill-focused courses that may bring fresh ideas. Contact information, I can put it in the chat as well, but please feel free to reach out to me with any questions. We do have a pretty standard process for our, bringing on practicum sites. We have an affiliation agreement, and it's fairly simple, fairly straightforward. We have a lot of really, really great students all of our students are awesome. So I definitely look forward to connecting with you, and I'll just put my information in chat. And also, if anybody's interested in the certificate program and sending any of your any of the folks that you work with. We will be starting a new cohort in the fall online. So it'll be a statewide cohort via Zoom. And so I'd be happy to send that out to Jeanette, and she can send all this information out to folks for as soon as we start our recruitment process. I think that's it. Thank you.
Well, thank you so much, Hilary. That's a great overview. And I hope people out there are now thinking, whoa, I need a practicum student. So thanks for putting your information in there. And, you know, personally, I find it very interesting what community health workers can bring to the table. So thank you very much. But I'd like to keep going with the other speakers. So thank you so much, Hilary. And, you know, congratulations on your new grant and all this really great work. So thank you. Our next speaker is known to many of us, our own Mia Taylor. Mia, I failed to pull together a short bio. So if you just want to introduce yourself briefly, but Mia is going to talk about how community health workers are used at Queens. So take it away, Mia.
Thank you so much, Jeanette. And it's really great to see so many familiar faces and names. So as Jeanette mentioned, I'm going to be representing Queens and our journey with, we call them patient care navigators, but they are community health workers, and really sharing with you a little bit about, how we built the business case to bring lay navigators into what has been a very traditional medical model. And some of the benefits. And this is going to be a very high level overview, but for any of you who are thinking of bringing on navigators as part of your team and you'd like more detail around, what exactly, how we built the business case, the more detailed job descriptions, things like that, I am more than willing to represent that. So I am a family nurse practitioner. I have been in Hawaii for 10 years now. First 2 years were with St. Francis Hospice as a provider. And then most recently at Queens, helping build the team-based model of care for our Queens physician network. And so that's just a little bit about my background. I'm going to go ahead and share my screen here. I've prepared a few slides. You can see this screen okay? So I wanted to start by just really sharing, kind of the overview again of how do you develop a navigator role in a team-based model of care. And it's really starting with that job description, figuring out what are the competencies. And this is where having a navigator that has gone through Hilary's program it's amazing, because we already have the list of competencies that they've been checked off on. So it really helps when they've been through a program like that. I can't speak highly enough of Hilary's program. We've had several of our navigators that either were already a navigator with us who then went through the program, or where we've had practicum students that we then hired. It's also really important to figure out the workflows. So this was a lesson learned for us as I mentioned, we have this traditional model of nurses, social workers, pharmacists, dietitians, licensed professionals. It's not only building the business case of hiring these lay navigators, but it's really developing well-defined workflows that will, I guess, for lack of a better term, I'm going to be politically correct here. Those of us who are nurses, social workers, pharmacists, it's hard for us to let go of patients, so to speak, and say, okay, so I've developed this plan of care for this patient. Now I'm going to let a navigator execute on that plan of care. That's a learning curve. That was a learning curve that I hadn't necessarily expected. And so by developing the workflows of, at what point do we involve the navigator and hand off the plan of care to the navigator, or more importantly now, what we're doing for our patients who really their biggest barriers as they come into the health system are those social determinants of health, or those social drivers of health. It's the navigator who is the first team member to engage that patient, because it's all about engagement. And the beauty of the navigators is they don't have an agenda. They aren't scolding patients. They're saying, what do you need? How can I help? And that engagement is so key. And so that has been really just amazing for our team. We've seen a significant increase in our engagement. And I see Martha's going to be presenting today, and she'll be able to go into a lot more detail about that. So I think that, we've seen definitely patient outcome improvement. The other thing that I really want to stress here is that we've seen, once our team really saw the value of navigators, we've seen improved professional satisfaction of the team with significant decrease in turnover. Because again, for us as professionals, when the needs of a patient and their caregiver or their family are so great, and we have a high caseload and we're trying to manage it all, you just feel like inadequate sometimes. And so being able to have an interdisciplinary team where everybody's carrying that load and each has their own role, it helps so much. Building the business case is really, it's been easy for me now. Initially, when we first started with our Queens Coalition and some of the others, it was really getting the traditional mindset changed, but I think they have more than proven themselves. It has helped with the finite resource of our workforce. Our licensed professionals are a finite resource. And so by really having that team-based approach, we've been able to leverage much higher caseloads for our licensed professionals with the support of the navigators, and they do provide a lot of support. There's financial benefits. I mean, let's face it, a navigator, it is not an RN, which is one of our, or a pharmacist, which are our highest cost team members. And so by bringing on, I can bring on 2 navigators for every pharmacist or nurse that I hire. And so it really does make a big difference for our team. Again, I've talked about this really building that business case. But for us, it was really, we needed to improve access. We needed to improve trust. We needed to improve engagement. And we needed to be able to get out into the communities because we knew these patients, these high-risk patients, were not coming to us unless they were in crisis. And we wanted to be able to avoid that. We wanted to really build that relationship. And that's really the business case you need to build here. And again, the workforce issue, I can't emphasize enough. We just don't have enough licensed professionals to meet the needs. So we have to think outside the box. And I feel that community health workers are the answer. And I challenge all of you who are in the hospice field, palliative care, community fields, if home health, we've been talking with our home health agencies, how can we build in navigators to really help with our teams? So the benefits, again, I've talked a little bit about this already. I'm not going to read this verbatim, but I really, a couple of key pieces in the benefits that I want to stress is that we have seen all of these benefits, but really truly, when we had our transitional case management team who was following patients for 30 days, after discharge from the hospital. It was a very traditional model. RNs were making phone calls and really trying to meet the needs of the patients. It wasn't until we brought on navigators for our, what we call our high utilizers, and I'm not going to take Martha's thunder, she'll talk more about this, but it wasn't until we did that we really made a difference in our readmission rates. And when we were able to augment that with our clinical care team, which is our home-based team, where if the navigators identified a medical need, nursing need, social work need, they could loop in those team members. And now for our transitional case management team, our RNs, when they're making those phone calls, sometimes their first referral is to one of our navigators to really get involved. That's when we saw our readmission rates drop for these highest risk populations. And I think that's something that we really can be proud of. Preventative healthcare gaps is another one. I just came off a meeting where, we have, we're working on building in health coaches into our team as well. And one of the things that came out of that meeting that I wanted to share here, and I think it's a really valuable thing, for patients who are reluctant to take medications, who are reluctant to follow the Western medicine type regimens. We don't have a lot of alternatives for those patients right now. And how great is it to have a lay navigator, a health coach, talk to them about, okay, you know, you're not interested in medication. We're not going to just cut you off and say, okay, fine, it's medication or nothing. You have high blood pressure. Let's talk about lifestyle. Let's talk about alternative therapies. Those are the pieces and parts that navigators can bring to the team, whether it's inpatient, outpatient. It makes a huge difference for them to be able to have those conversations because patients feel heard and they feel supported. So this is a list of the responsibilities. I'm more than happy to share these slides too. And this is just for our team, some of the things that we have them do. And it's, you know, I think a lot of the things that Hilary probably talked about or that Martha's going to talk about. It's really meeting the patients where they're at and supporting them in all the things that currently keep them from being able to effectively, you know, manage their healthcare journey. And it really is, I think, you know, I jokingly say this, it's, you know, in the job description, I think we all have this in our job description, other duties as assigned. The navigators have lots of other duties as assigned. And they're of that mindset of what can I do to help, right? And it's sometimes those little things that make such a big difference. And, you know, the last bullet point, being an advocate for the patient. Our navigators are amazing advocates for the patients. In our IDT, oftentimes the navigators will be the one that they're the voice of the patient for us and say, but hey, wait, guys, they're never going to be able to manage that in the home setting. We have to think about this differently. So this is an example of our requirements for our job description currently at Queens high school diploma or equivalent. We prefer community health worker certification or medical assistant, depending on what department they're working in. Obviously, you have to have a driver's license, those types of things. We'd like to have experience in the human services field, if possible, or community services. And, you know, this can be a variety of things. You know, we have students that come and applicants that come and they've been volunteering at their local church with a kapuna, or, you know, all of those things count. So, you know, I always tell people, don't let this like deter you from applying. You know, we've had some amazing applicants apply from all walks of life. We have community health workers who have bachelor's degrees, you know, that just, they love what they do. This is what they prefer to do as part of the team. And just kind of, you know, end by saying that our journey with community navigators is not over. Our next phase, I briefly mentioned, is the health coaching piece. And I had the pleasure of just, I think it was Tuesday night, right, Hilary, presenting to the current cohort of students that this is something that I'm really trialing, of just taking it to that next level for the navigators to be a health coach. And we actually have a very seasoned health coach who is working with us right now, who will be doing that training for the practicum student. And we're hoping to embed that into our team in addition to our navigators. And currently our health coach model, the health coach works very closely with our pharmacists. And because what we find when we get patients referred to our pharmacists, they are very complex. They usually have polypharmacy. It may be high-risk medication, it may be adjusting medication, substance use disorder patients, we may be weaning off benzodiazepines, things like that. Health coach has really, really been beneficial in that model. So that's our latest journey that we're just starting to embark on. So I can keep you updated on how that's going moving forward. So I will stop there, Jeanette, and hand it back over to you. Thank you all for allowing me to present, and I will also put my information in the chat. I'm happy to speak to any of you later after the meeting. Reach out to me if you have additional questions.
Great, Mia. Thank you very much. Hopefully that was also inspiring for people to see practical examples of how does this roll. Our next speaker is Martha Boyd, a real community health worker. So Martha is going to actually share about her experiences. We had a talk with Martha on Monday, and it was very illuminating and really inspiring to me. So Martha, if you could take it away.
Okay, thank you. So my name is Martha Boyd, and I work for the Queen's Care Coalition at the Queen's Medical Center. And I really want to thank you for letting me come here and share my experience. I wanted to also point out that because of Mia and because of Hilary, I was very fortunate to be able to do my practicum at the Queen's Medical Center. So it was easy for me to do the 120 hours. I was just working those hours anyway. And for my, you know how Hilary talked about we have to have a goal when we're a practicum student. So my goal, one of my goals was, I noticed that I used to be a cancer patient navigator, and there was no spirituality in the cancer center. And you know, when you're really sick, sometimes people, they get mad at God or they find God. So I talked to the Reverend Al, who's part of Queens, and I said, we need to get the chaplains in here to talk about, you know, to talk to these people when they're sitting there for 8 hours for their chemotherapy. And that started the chaplain service in the cancer center. So what I did was, when I was already out working with the homeless people, we're so concentrated on the person. You need food, you need a place to stay, you need this. And sometimes people don't realize that homeless people feel invisible. They lose their sense of self. They lose their connection with anything spiritual. So I started a chaplain program for the homeless people, and that was like 4 years ago, and it's still continuing on. It's gone through 3 chaplains because they move on, they move away, they graduate. But it's non-denominational. It's totally just talking, unless the person wants to talk about God, it's totally like, where are you at spiritually? How can I help you feel better? How can I help you get your self-esteem better? So, you know, if you're thinking about doing a practicum in your workplace, please do. It's the most rewarding thing if you can especially do it where you work, which is what I did. It takes loads of stress out of your life. But I was asked to talk about hospice and how my role is with hospice. So I'm going to talk about a patient that I had. He's a 70-year-old Filipino man. He was homeless for 14 years, estranged from his family. He had a storage unit. So during the day, he would, you know, go and hang out in his storage unit where it's nice and cool and no rain. And at night, he would sleep at Next Step Shelter. And for those of you that don't know what Next Step Shelter was, it was run by Waikiki Health. It was on the pier. It was a huge warehouse divided by cubicles that were about 4 feet high. And you stood up, you could look into the other person's cubicle. There were birds flying around. So it was not the best place, but it was a safe place to sleep. So I met him when he came into Queens, to Queen Emma Clinic, and with the help of the social workers, I got to meet him, and that he had a lump in his throat. So it turned out to be cancer. So he was, you know, he was in a lot of pain. By the time I picked him up, and I think because we got him to a safe place to stay, sometimes when you're dealing with homeless people and they're out on the streets and they're so tense and they're so worried about surviving, they ignore all the symptoms in their bodies. To when you can finally get them to relax, they notice that, oh, I have a heart condition, I have this, I have cancer, but it spreads so much that it's already kind of too late to help them. So the next step would be pain and palliative. So I teamed up with the pain and palliative social worker at that time, who was Julia, and we talked to this gentleman, and we found that he was estranged from his family. He had 11 brothers and sisters. One of them owned a care home, but didn't want him, and his children were talking to him. So I asked him if I could have permission to call up his son to see what was going on with him. So he said yes. So I called up his son and I talked to his son. I introduced myself, you know, that I'm his navigator. And I said, I wanted to talk to you about your dad. You know, he's really sick. And the son told me, well, you know, I drive down Ala Boulevard and I see my dad there walking all the time. And I did kind of notice he was like kind of getting weaker. And I said, did you ever stop? And he says, no, didn't stop. And so, you know, not my concern at that point to find out why didn't you stop. That you could tell there was a lot of history of family trauma. I mean, my gentleman was a meth addict. He didn't have a job anymore, was estranged. So my goal and Julia's goal was to get this patient connected back to his family. So Julia had a conference with the pain and palliative doctors, with the social workers, with myself, and we brought in his children. Well, we brought in his son. We came to find out that his other son was missing because his other son also had an addiction problem and was nowhere to be found. But the son got connected with the father, and it kind of like didn't matter all those underlying things that happened. The son met the daughter-in-law. The son, the patient met the daughter-in-law. The patient got to meet his grandchildren, and the patient did not have a lot of time. But Julia taught me, the social worker taught me something really important. Even though this man was kind of at the end of his life, you know, he only was going to have a couple of months to live. She asked him, what's important to you right now in the stage of your life? And he says, oh, I want to go holo holo. I want to still have my independence. So, you know, the son wanted to take him in. We wanted to put him in a care home. We wanted to put him somewhere where he wasn't out on the streets. But he said, no, I want to go get up, walk across the street, go to Starbucks, drink my coffee, and be happy. So that's what we did. We left him at Next Up Shelter, and every weekend for a month or so, his son would pick him up and take him to the beach, take him to the house for family dinners. You know, he was happy. And when the time came for him to go into hospice, it was a difficult conversation. So the doctors kept saying, you have tumors. And the patient, I said, do you understand? He goes, no. And I had to ask the doctor, he doesn't understand what a tumor is. If you tell him he has cancer, he'll understand that. So the doctor finally started to change the words to cancer, and you could see the light in the patient's head go, oh, I have cancer. I'm not going to be able to holo holo all the time. And myself as being a patient community navigator, helping his family help navigate into hospice was very precious to me, because after 14 years of being estranged from his family, when he did pass away, he was surrounded by his family. And it was, to this day, I think about him because his son and sister-in-law, his son and daughter-in-law are best friends with one of the navigators that's in the Care Coalition's parents. And they happened to get together over Christmas, and they were talking about the kindness that Julie and I gave their father, and that they still have his ashes. And when it comes time to, you know, figure out what they're going to do with his ashes, we're invited to that ceremony. So little acts of kindness, little acts of humanity. As a community health worker, I think that's what I offer, as Mia was saying, to a team. Because you can have a pharmacist, you can have a nurse, you can have a doctor, but they're so clinical. They're so set on getting you better, you know, making sure your medicine's right, doing your blood pressure, doing all this, that they forget, I think, that there's a human being in there. And so how I think a community health worker could help in a hospice situation is by joining your team of liaisons, doctors, nurses, social workers, as being a warm welcome into the community, into hospice. You know how when we discharge, we're always talking about warm handovers, you know, making sure that the patient's connected to this and telling their HMSA service coordinator, this is how he is, he likes this. Well, why don't we change the narrative and make a warm welcome? You know, we could get the referrals to hospice. And I, as a community health worker, could make that first phone call. Hi, my name is Martha. I'm a community health worker for hospice, and I'd like to come and visit you so we can talk about maybe what you understand or don't understand about hospice. And I could see how your family is. That way I could go visit the patient where they're at, which is what community health workers do. We meet patients where they're at, in their environment, you know, in a care home, in, you know, living in a shelter. And I could start the conversation of, what do you understand? What don't you understand? That way, with my knowledge, I can go back to the team, to the liaisons, to the nurses saying, okay, this is how he feels. These are things he's not going to understand. So don't, you know, the family doesn't want him to know he has cancer, or the family doesn't want him to know he's going to die soon. So don't bring these things up, or we're going to have to deal with how to broach these things. That way, when the team goes in and starts talking about, you know, we're going to give you an IV, we're going to give you morphine, we're going to give you this and this and this. First of all, the family's not going to be in shock, because I've already kind of told them, we're going to talk about these things, and it's going to be a difficult conversation. So that it's going to be a process. But also, another good thing about having a community health worker in your system is that now in my job, I consider myself a quarterback. So even when I have patients out on the streets and they're connected to their service coordinators, their doctors, all these people call me and say, can you do this for my patient? Can I do this? Can I figure this out? And then I take that information and I do it to help the patient. If you have a community health worker in hospice, what that would help is, because, you know, the culture is that I don't want to call the doctor. It's kind of stupid. I don't want to bother the nurse. I don't want to bother the social worker, but I can call Martha. Martha always has time for me. I can be that initial phone call. I can be that phone call that they say, oh, Martha, I don't know whether I can, you know, talk to the doctor about this. Is this something I should really talk to the doctor about? And even though I'm not a clinical person, I can have enough knowledge to say, okay, take a breath. Let me get a hold of the doctor and I can help you solve this problem. Or, I don't know. That's a really good question. Let's explore this and let me get back to you. So to have a person like me, a community health worker in your organization, is always a win-win. And with so many people graduating through Hilary's, you know, classes, I graduated in 2018 with my certificate. Number one, I felt so accomplished because, you know, in my heyday, it was hard for women that were single parents to go to school, to finish their education, because we had to raise our children. And I had family support, but not that they're going to take care of my kids for 8 hours while I go traipsing off to school, right? So what Hilary's program did was give me a sense of accomplishment, but it also taught me that for the 40 years that I've been in direct patient care, the things that I was doing in the textbook were the correct things to do. It was in me. And then what Hilary's classes did was help me fine-tune those. And not that I'm such an expert now, because every day it's a different patient, different situation, different everything. You learn and you build upon those building blocks. And I'm learning every day how to be accommodating, how to be flexible. So if you're sitting on the fence about having a community health worker, look at the statistics that Mia gave you. Look at the statistics from the Queen's Care Coalition, how we've dropped, you know, readmissions, hospital visits, how we have the privilege that nurses and clinicians don't have of being with the patients and just talking story with them. And then we're not selfish. We go and we talk to the clinicians about that, which makes it all patient-centered care, which makes it all the well-being of the patient, which in my case and Mia's case is living the Queen Emma way. You know, it's our Kianoli, where we're doing the right thing at the right time at the right place. So thank you very much for, you know, allowing me to speak here. Thank you, Mia, for bringing this wonderful program to Queens. And thank you, Hilary, for being the most amazing teacher, friend, and peer that I've ever had in my entire life. Thank you.
Wow, Martha, that was fabulous. I certainly, you know, you certainly make a great argument as to what community health workers can do. So I hope Very shortly, we have just 2 more brief presentations, and then we're gonna have a conversation. And I hope some of the folks here from hospice are now thinking, okay, how could I use a Martha? What could we be doing? So boy, that was great. Thank you very much. Full disclosure, we talked for an hour on Monday. So Martha has lots of other good stories about what she actually is able to do. So it's really inspiring. So thanks again, Martha. As I said, we have just a couple more, two more presenters. The first one is Hope Young. Hope has been doing quite a number of presentations for community health workers. So she's just going to talk a little bit about that and the work she's been doing.
Man, I feel inadequate going after Martha. She just kind of sold it. I just absolutely love the work that she's doing. So we have been doing advanced care planning sessions for community health workers, and we're trying to reach as many as we can. We really see that they are a bridge and that they have that time to actually build that relationship with the people they're working with. And remember, when we say community health workers, they're working for their community. So whether that's culturally, by language, their ethnicity, or in their neighborhoods, that's the people that they are working for, which builds a lot of trust. When they are working with that population, they actually have the time and the time to go and talk to them, which is why we see community health workers as being such a great opportunity for advanced care planning. So we have been working with various organizations. We started with Kapiʻolani. They invited us to do some work with their community health workers. We started with their leadership. Leadership passed it down to community health workers. We have a High Five, that's the Hawaii Public Health Institute. They're running a series right now for their community health workers. And we just started working with the Hawaii Alliance for Pacific Islanders. They're called HAPI. And they're a new organization, and they actually look at these smaller communities, the Pacific Islander communities and Native Hawaiian populations. So we are really wanting to get them so that they have their resources ready, so that when they initiate these conversations, they feel comfortable, but also so that they can learn from their patient what matters most to them. And so they can be that advocate as well for the team that they're working with. We just find that they're such great people. We have, I did see another name in there that we may have time for at the end of this, but we see the value in the work that they do and the ability that they have to take the time to have these conversations. When you go to a wellness visit, doctors don't have time. They really don't. They have a checkbox and they really have to go through what they need to go through, unless there's an advanced care planning appointment added on to the wellness visit. But we see the community health workers as being able to initiate these conversations, facilitate the documents, and even be with them at the doctor's appointments, helping the individual with expressing themselves for doctor. So we see the value in what they do, and we want to keep working with them. We will be working with the KCC's cohort coming up in the next couple of weeks. We will be doing the advanced care planning sessions for those classes as well. And we're just excited to work with community health workers. So thank you.
Thank you, Hope. Yes, I wish I could have transported you all to KPT on Saturday morning, where there was a group of folks talking about advanced care planning. We had, I think, 2 different languages running, and people from a number of 3 different languages, plus other folks who spoke English well. So it was, and very interesting, and always good to, oh, there's Kahlo. Always good to have time to sit and listen and help people figure stuff out. So thank you very much, Hope. We have one more formal presenter, and maybe we can get Kahlo to present later just briefly about her experiences. So our next speaker is Naomi Morita.
Okay. Hi, everybody. First of all, Martha, I impressed by the work that you're doing, and this is a great example of the incredible work that you do to help our people access the best quality of care. And so thank you for that work. And also thank you for all the people who train you to get to that point, Hilary, Hope, etc. So thank you very much. I am, but also wanted to just mention, I think that it's really great to have forums like this that describes what community health workers do. Just like palliative medicine is so confusing to most people, including fellow physicians, community health worker term is very confusing. And I just want to give an anecdote for myself. When I first joined Pōhala, which is a palliative care advocacy organization, about a year and a half ago, I didn't know what it was or what it is. And just before that, I think someone recommended to me that I should sign up for a community health worker seminar. I said, okay, I'll sign up. So then during the registration, it says, are you a community health worker? Now, I didn't know what a community health worker is. And I went, okay, I'm a physician. I work in the community. Okay. So community health. Well, I'm a physician, so I work in health. And it said worker. Well, I do work and I work hard. So I'm a community health worker. I checked the box. Yes, I'm a community health worker. And so when the seminar came on, they had all these breakout sessions. So they put me into a group with all the community health workers. And I was so confused because obviously I didn't know what a community health worker was. That recently there was some conversations and I realized, well, the way I've heard of community health workers is at Queens, they use navigators like Mia mentioned, but also when I first started Kaiser, many decades ago, in the emergency department, they use health advocates. And so that's a term that I was familiar with. So all these different terms were really applied to community health workers. So it's really important to have this sort of forum to share the information, just like what is palliative medicine. And there I go now. I'm going to share I'm Dr. Naomi Morita. I'm a hospice and palliative medicine physician. I was up to about a year and a half ago as a hospice medical director. Along with Emma Grote, I work with Mia Taylor. And I'm amazed how I have worked across the country along at the same places as Mia myself. So Mia, we were both together in Miami and also at St. Francis. And now Mia and I are together with Pōhala also. That's pretty exciting. Along with some other people on this thing, Jeanette Kojang and Hope and Dr. Ray Seitz. So I am fortunate to have joined them in their group. So they started this organization before me, and I joined, like as I mentioned, just a year and a half ago. So just to preface, before I joined Pōhala, and
Naomi,
the others, you can, yes.
Can you make it a full screen presentation?
Well, yeah, I will when I change it to slide. I just wanted to give a little preface. So the thing is, before I even joined Pōhala had already been approached by MedQuest, requesting Pōhala to see if they had any solutions to help them come up with solutions to help provide their seriously ill patients with opportunities to utilize home and community services so that they could remain at home or return home. And so a number of projects were proposed to MedQuest, conditionally approved, including this one. So others have submitted work to them. We're waiting for final approval. In any case, so this has been a many decade dream for me, and it's a perfect combination right now with the need for increasing healthcare workforce. As we all know, workforce in all fields, not only in healthcare, is very, very much needed. There's a paucity of workers, and certainly in healthcare as well. So this is a perfect meld, I think, and we're hoping for final approval. In the meantime, we have started to do work, and Hilary has helped us move along in major ways. Okay, so project to recruit and train public high school students, seniors, for careers as EMTs and community health workers. The concept is to support MedQuest members, as I mentioned earlier, living with serious illnesses with home and community-based services to help them remain at home or return home by expanding the needed allied healthcare workforce with early onboarding of high school students to be able to provide high quality palliative care as community EMTs and CHWs. The goals of this program is to provide palliative care education training tracks within public high schools, high school health academies, to be established for training of these disciplines. And core curricula will be developed, or is being developed, to teach palliative care knowledge, skills, and competencies to these high school students at an introductory level. And in fact, there's 3 of us working on this, and Dan Weiss who spoke earlier, and I will be giving our first talks to the community health worker students in early college at Waipahu High School next month, thanks to Hilary. So thank you for that. We wish to establish sites for practicums, as has been discussed earlier, apprenticeships where they can earn as you learn. And I have heard from one of the HR heads from one of the large major organizations who want to hire these community health worker students and EMT students while in training, not just as apprentice, but to work and to provide opportunities for employment after course completion, where MedQuest members with serious medical illnesses receive care. So by the way, even before receiving final approval for our proposal, we are moving forward in providing this education to these classes. And some of the things that we will include in our curricula are the elements of palliative care. The learning objectives are provide PC, describe PC and how it compares with usual disease-modifying care and hospice care. Explain who may benefit from PC, how it can benefit them, and understand the role of the CHW and other members of the palliative care team. Understand the dynamics of communication among PC members. So this is a schematic that will be shown demonstrating how hospice is a subset of palliative care. So not all palliative care is hospice, but all hospice is palliative care. And the following figure will show how that is. So in common between palliative medicine and hospice are that it focuses on comfort care, reduces stress in all kinds of ways, offers complex symptom relief related to serious illness, and physical and psychosocial relief. The differences are with palliative medicine, it's paid by insurance or out of pocket, whereas hospice services are provided by some sort of insurance, including Medicare, Medicaid, and private insurance. With palliative services, it can apply to any stage of disease and preferably provided from the very beginning of the diagnosis of a serious illness. Whereas with hospice, services are provided when the length of life of a person is expected to be 6 months or less. With palliative services, it can be provided simultaneously with curative services, whereas with hospice, curative services or curative treatment is not provided and not considered beneficial at that point in time. And with palliative medicine, it typically occurs in hospitals, but there is a caveat. So during the pandemic, the rules have been changed, and that in which palliative medicine has been able to be provided and compensated financially by the different insurance programs. Before the pandemic, before the COVID pandemic, and we will see what happens on May 11th when the pandemic is declared ended, we'll see whether palliative services as an outpatient will continue to be compensated financially. So there's much talk about that at this point in time, and hopefully Congress and Medicare will decide to continue to compensate outpatient services and home-based services in palliative medicine. Hospice care is provided anywhere a patient considers home. So homeless, in addition to home, and also in different institutions, adult care residential facilities, care homes, long-term care facilities, etc., wherever a patient considers home. We wish to emphasize that there are 3 conversations to improve quality of care. To teach the students to discuss the options available for care, to understand the difference so that the CHWs and EMTs can explain to other people what the difference is between palliative medicine and hospice care, and to give patients more control over their care with earlier advanced care planning conversations, which Hope and her group are teaching various people and institutions. Hilary already spoke, and as well as Mia spoke, and Martha, the various capabilities of CHWs have as part of a healthcare team. And so again, sharing this information, they form as liaisons between patients, caregivers, and medical teams. They are in the communities and the bedside. They can increase access to care, do screening and preventive services, system navigation, and care coordination. One of the things we hope for them to do is to detect concerns early on and send out first alerts to medical teams to initiate rapid intervention. The unique strength of CHWs have already been discussed much by Martha, to develop rapport and trust with patients, loved ones, and other community members. Due to shared culture and community, CHWs improve health literacy and enhance the cultural appropriateness of care. The EMT's roles as a part of the healthcare team are multiple as well. They can, as we know, they respond during crises, and they can review and explain the patient's provider's orders of life-sustaining treatment. They can explain it to the patients and their families and loved ones as to what it really means. They can assist patients by addressing fears and concerns and communicating with the patient's healthcare team. They can explain options for care, whether a patient can remain at home for this care, or whether they can be transferred to the physician's office, to urgent care clinics, or to the ED, emergency department. They can do home and household health checks, work as home health aides, and provide additional medical support in the community, including hospitals, clinics, urgent care, and home-based organizations. So a lot of versatility with EMTs. So just a brief cap of some of the curricula that's going to be involved in teaching the EMTs and CHWs into introduction to PC. Any questions?
Thank you, Naomi. Let's see if there's any questions from folks. We can also just open this up and see what people are interested in. I want to really thank you for taking the lead of this and having success in this vision of yours to help the health academies and the kids in the health academies to be learning more about palliative care and be on their way, hopefully, to these different careers. So thank you, Naomi.
So I'll just give you a little status update on that. So we are waiting, of course, the final approval from MedQuest. In the interim, the DOE and community colleges have responded really positively in terms of trying to come up with solutions. So at this time, they are working on developing the roadmaps to having these classes become early college accessible. They're being very conscientious in terms of supporting the students so that they're well supported for success. And so this year, while awaiting, they want to be able to provide them with the prerequisite classes in high school, like medical terminology, math, English, so that those criteria are fulfilled in high school. And then when the early college class or when they go to the community college, that they can then easily enter the classes at that level. So that's where the DOE and community colleges are working on at this time. And then hopefully they'll get launched further next year.
Great. Dan, you had a comment?
I did. I had the good fortune to work in one of the first home-based palliative care programs in the state of California for over 13 years. That's at Sharp Healthcare in San Diego. Very forward-thinking organization. And I put a kind of a wordy note in the chat that in addition to hospital-based palliative care, which does get reimbursed, there are home-based palliative care programs, and for many of them, the question is figuring out a sustainable financial model for how to get paid. Here in Hawaii, we're hoping that our state health insurance, there's a lot of excellent work that's already taken place with Hui Pōhala, Kokua, and many other healthcare organizations pulling together to hopefully get the quarter of our statewide population that's covered by MedQuest to receive a bundle of high quality palliative care services in their homes, because ideally the palliative approach, as Martha's presentation showed, and as Mia's and Naomi's presentation showed, we need to take the palliative approach to care way upstream and bring it to people where they live and where they receive outpatient health care. and not wait until they're flat on their back in a hospital bed. Although that's what I do. That's my other day job now at Castle. But ideally, it's very good to provide this type of supportive. In Hawaii, it's also known as supportive care, which really has a good track record of reducing hospital readmissions. Our program, our numbers were very good. Anyone who's interested, I can send you a link to. It's a somewhat dated study published in 2016, but it described how our home-based palliative care was able to reduce inpatient days, ICU days, total healthcare costs by like a 4 to 6-fold return on investment. And it's a fantastic approach, and the insurance people are just starting to catch up with it. Fortunately, HMSA, our largest insurer in the state, covers home-based palliative care for up to 90 days. And we're hoping that more and more people in Hawaii will be able to receive this type of care where they live, which will help them feel better and manage their condition at home and spend more time at home with their loved ones and less time in our wonderful but overstretched hospitals.
So first of all, I want to let you know that the CEO of Pōhala, Dr. Grace Seitz, is with us today. There's a picture of her, and she is the creator of the HMSA Supportive Care Program, which was also based on the home-based palliative care program that she and others started at Kaiser. So, you know, kudos to her and her group. I happen to be one of her sidekicks. Okay. And then the other question is, how long has palliative care been around? So palliative care, so Ray and I, Ray is, you know, a year preceding me, but we've been, you know, we're board certified in palliative medicine in 2005, wasn't it, Ray? So it's been around for a long time, for at least.
I was certified in 2002.
Okay, so it's been around for over 20 years. And this is the thing, that's the challenge about palliative medicine, is that it's poorly understood even at this time, right? A lot of people have not heard about it. A lot of people misunderstand it. So that's still a task for us to spread the word. And in addition to supportive care through HMSA, there is also concurrent care. So by the way, supportive care and concurrent care are names of outpatient palliative care programs that different insurance companies have. So HMSA, supportive care. Concurrent care is through the VA and through UHA, United Health Alliance. So UHA and VA have some slightly different criteria, like the UHA is unlimited time frame, same thing with the VA. UHA will accept all diagnoses. The VA had some limited ones, but now they're thinking about opening it up to all diagnoses. So this is an evolving field.
So yeah, thank you, Naomi. For people who want specifics about what's available where with palliative care, there's good information on the Kokua website. Feel free to contact me. We do want to pull the discussion back to community health workers. And I think, but it's a great example if you have community health workers who can actually explain, especially when the benefit comes, what is the palliative care services benefit from MedQuest? What does it actually offer? I think that'll be, you know, seeing community health workers as part of our team is really exciting. I see Leslie has her hand up, and we also have another community health worker who's joined us, who I hope can also just introduce herself for it in a minute. Leslie, there you go.
Yes. Thank you, everyone, for the presentations. It was really impactful. So impactful that I realized that I am a community worker, health worker. Yesterday, I had a meeting with Jeanette and Hope, and they asked if we were involved with community health workers. Alexis, our nurse practitioner and palliative program director, and myself. And I said, I don't think so, but I definitely need to get in touch with them. And then after this presentation, I'm like, oh, well, I am a community health worker. I'm with Islands Hospice. I am the patient care I wear 2 hats. So I'm actually a liaison, but I'm also a patient care navigator, which was also bulleted as a title for community health workers, which was like ding in my head. But so I do a lot of what you discussed, but also like my liaison duties, as well as the palliative liaison. So the one that's helping Alexis and Islands Hospice build our palliative program. So this was very, very just perfect for me to sit in on. And I think it would be great for me to partner with many of you going forward so we can continue to support our community as well as build our palliative program. Thank you.
Great. Well, thank you, Leslie. So folks, be thinking about your questions. Kalo is somebody that I've now known for a whole 2 weeks, which it seems much longer than that. Kalo, you just want to introduce yourself and talk a little bit about community health workers. And now that you've heard our presentation a couple times, I'm interested in also your take on how community health workers can be involved with serious illness care.
Well, aloha, everybody. I'm so sorry. I have a bunch of family here. They all want to come, and it's spring break, and it's just like, so if you hear noises in the back, I have 2 8-year-olds. Anyways, so thank you for letting me, Janet. I'll take up just maybe a couple minutes. So I'm a cancer survivor twice, and how I came about this whole thing is I work for the University of Hawaii Cancer Center as basically a healthcare worker and advocate. I basically, long story short, I meet people in the public. I make sure, ask them, have you done a mammogram? After the mammogram, and if they haven't, I basically ask them if they want to do a clinical trial. If they don't want to do a clinical trial, I still take them to Queens. So I service this side of the island, which is the East Oahu, whereas the windward side, Hauula, Kahuku, all the way to Waiho. I mean, I even took some women from downtown Honolulu, a couple women I met and taken from Ewa Beach. So I'm all over the place. But the main thing is that it's really interesting coming into this as a patient and then working in the community. I never knew about palliative care, and thank you so much. Interesting enough, Janet, Pōhala, she said hi, and Dr. Cass, they said hi. And guess what? Our outreach person from the Marshallese that I work with, Crush Ryan, she said, I would like to get more information about palliative care. And thank you so much, Morita. It was an excellent conversation we had in our meeting yesterday, and this was brought up, this whole subject. I did explain that I was with Kokua last week at KPT, and it was amazing. The people that walked away, I'm not going to say that they're limited with English or anything, but what I'm trying to explain is that they have the knowledge, but they don't know where to direct it, you know, and one is a state translator that showed up. And so this itself, what you guys are doing is amazing, because even I in the community, even though I could have passed away in the state of Hawaii, all of a sudden I have to get this directive, advanced directive, and then all of a sudden you have all these other different languages of palliative care, and you're like, what is that? So this in itself is it's a great opportunity to reach out. And on top of that, I'm going to tell you this. The Marshallese last week and the Tongan Pacific Islanders that came, and Samoans, they really, really were very engaged in this, Janet. And I did get a lot of feedback from them. And they just said, we need more. We need more. And so I congratulate, this is great. Sorry, it was an hour late, but this was a great program and everything else. So I'll take it. I don't want to take too much thunder.
But well, thank you, Kalo. And let's keep talking about, you know, Marshallese and the Coach Ryans, and happy to hook them in. And as Hope mentioned, the Happy group want to expand to other Pacific Islanders too. So this is, it's really, it's so wonderful that people really resonate with what we're talking about. And I will say on Saturday, it was just so clear how many people are caring for their families who are very sick without understanding what palliative care is, how palliative care can help, why you would need an advanced directive, what hospice really is. So it really is good confirmation that this work is important. So maybe Hilary, you want to talk a little bit about this. Julie Young asked, is there a CHW certification, or is this affirmed to your program through the community colleges? Because also I was wondering Are other community colleges also doing this, or is it all virtual now through KCC? How does that work?
Yeah, so Maui has a program. Maui's actually, we started this program at KCC with Maui College about 6 years ago on a TACT for grant. And so we have, same curriculum across the board. So Maui, Windward Community College has been offering classes on and off. I'm not sure exactly what they're doing right now, but we are actually getting together very soon to see what everybody's doing. Windward was offering the first 2 classes inside of the women's prison. And so that we've had a few people who were released come and finish the courses with us and graduate and go on through their practicum to get hired at their practicum and to go on. So some really great successes there as well. But yeah, Windward, and then Leeward has some human services courses. So it's at Maui, this is nestled kind of within their human services associate's degree. And so there's some classes that are similar across the UH systems. But KCC, we just offer the certificate of competence as a community health worker. And we've, because of the amount of funding we've received over the years since COVID, we've been able to really ramp up our training and offer the statewide programs. But I know like UH Hilo, so when we did start the TAC 4 grant 6 years ago, we had Kauai, Hawaii Island, and Maui and Oahu. So it's everywhere. And then it's just kind of starting to get reawakened as well. So I know we've been doing this statewide online, but I know people are really interested in starting up the Hilo. I think I've heard Hilo, and then Kauai is actually offering a public health associate's degree, which I'm really interested in learning more about. I just heard about. So we're kind of some of the similar courses as well.
Wow, that's great. Well, that's very cool. It's almost been 2 hours, people. So thank you very much. I'm wondering if there's any questions. Is anybody inspired to start this up? Oh, Kahlo has her hand up. Go ahead.
I'm so sorry to jump in here, everybody. I'm just super, I'm super, let's say I got a fire underneath me. Janet, thank you so much. I just wanted to bring up something really quick. There is a cohort research that's going to be coming very, very soon in the next, hopefully the state doesn't crash us or anything else with the University-wide Cancer Center. And this research is going to be about everything that we're talking about, but we're adding it, we're expanding to the Filipino community too. And it was brought up in our meeting that this is a community that has been, that's kind of divided since COVID. And so I just wanted to bring this up to you guys here because I hear that a lot of people here are very familiar with the law. I don't have a problem. I'll talk to the wall, and talk to people. I mean, I grew up in the Bay, so, I don't care. I just talk to the wall. If I was at CVS just now and I saw this little girl crying and I looked at her and go, why are you crying? The mom is Filipina and I was like, okay, what you need? So I bought whatever she needed, but that's just me. But what I'm trying to bring up is that we're trying to reach out to a lot of the people on the island. And I know there's disparities within the communities. Like from my community here in Hau'ula, we live right next door to BYU Hawaii. Everybody, we assume that's educated in this stuff, and a lot of them aren't. Just getting a mammogram is like pulling teeth. So I just wanted to bring that up. If there's a way that we could, Janet, this is a community that the Cancer Center wants to try to reach out even more to. So I'm just putting ears to the ground and everything else. And I know this is another platform, but I really, really appreciate it because this right here is, you guys are helping me further what we need to do together as a community. And that's my passion. And I really, really appreciate it and everything. And I know I'm rambling on, but like, again, I just want to like put it out there and everything else that I love this program and I love this. And like I said, palliative care and the advanced directive, they go hand in hand. And Lord help me with my culture, because a lot of Tongan people, when they go and unfortunately pass or they're on their final hours, that's when we learn it. My community. So that's my little rant for the day.
Well, Kalo, I look forward to continuing to work and to learn from you and strategize about how to help the Tongan community. So it's very inspiring. Okay, so one question, and then I think we can wrap up. Mary Elizabeth, who is a social worker in a cancer clinic, are they doing college credits for the kids in high school academy as well, or is it only the training with no credits? Hilary, you can speak to that, please. Oh,
yeah, that's our program. Yeah, so
Yes.
we offer. We've actually been offering our community health worker certificate program at Waipahu High School for the past 5 years. So the past 3 years we've been offering the complete. 2 years. We're starting our third. We just hired our instructor. Very exciting. But we are offering the complete certificate in school. So students are graduating high school with a certificate of competence for community health worker. And those are all 4 credits. So we just transitioned into early college, from non-credit to early college. So yeah, it's exciting. Yeah. And we'll be starting our third cohort of completers in high school. We had, but in the prior years, we were offering a couple courses and students weren't really coming back to school to finish. We had maybe graduated like 4 out of 25 or something. So we decided to kind of jam it all into their senior year. So they work really hard in the summer. And then in the fall and the spring, they do their practicum. So it's always really challenging to find sites for our youth. So if anyone's really interested in hosting youth under 18 for their practicum, that would also be really, really helpful.
Great. Well, this is, it's very inspiring. I'm curious if any of the hospices think, okay, this is great. I want to pursue this. If you don't see anybody volunteering, but I would love to hear what people have to think and, hear what people are thinking after they've heard about this. So, okay. So thanks everybody. That was really fabulous 2 hours. I hope everybody is as inspired as I am about this. I really want to thank all of our speakers for making time to come today. I know everybody is very busy and has lots going on, but the amazing work of community health workers. So thank you very much, everybody.